let you read the cartoon. I'll say you're suffering from an arrow through your head, but I need to order a bunch of tests to figure that out, type of a thing. This goes along with what you were saying earlier today, that, I remember my mentor in residency used to say, treat the patient, not the laboratory studies and not the CT scan. Listen to the patient, they'll tell you what's wrong with that. With that having said, we still use the laboratory results, the blood test to prepare patient. It's also used for intraoperative monitoring, post-operative monitoring. So in the operating room, we sometimes draw blood. Operatively, we draw blood. And also long-term maintenance, patients that are on particular medications and procedures and any health issues need to have their blood work checked. What we're trying to avoid is do what's known as a shot in the dark when a patient comes and says, I've got, my left earlobe, and we say, well, I'm not sure what it is, so let's order a whole bunch of panel of blood work and figure out what can cause that. And then if you order enough laboratory results, you'll find something that doesn't fall into the normal range, and then you end up chasing that, and not necessarily for the good reason. So the rationale of this is that to start following specific index markers. So if we were to group these, and this is a very limited summary list of tests that we order, complete blood count, which is sort of the basic sodium, chloride, potassium, bicarb, simple evaluation for kidney function, lipid panel, thyroid function, hepatitis panel, urine analysis on vitamin, and I'll go through each one of them sort of a little more detailed. And as I said, there's more to this that I'm going to talk about a little later on the blog and all that has to do with specific values and all that. Complete blood count, that's sort of the CBC that everyone is probably familiar with. It's the most commonly ordered blood test. A CBC on a very simple format has essentially 4 numbers. It's the white cell count, the WBC, the hemoglobin and hematocrit, and the platelet count, the sort of 4 indexes. Then you get into a lot more detail, different parts of the CBC. Then you get the MCV, MCHC, which essentially with the CBC, it tells you what your bone marrow is putting out as far as white cells are concerned, and the white cells are essentially the soldiers that fight infection and or inflammation. The white cells can be divided into differentials of whether they are neutrophils, eosinophils, or other specific branching of the blood work of the CBC that indicates inflammation versus infection. Hemoglobin, hematocrit, as I'm sure we're all familiar with, it essentially shows the degree of the anemia. Hemoglobin and hematocrit, even though we use them casually interchangeably, they're 2 different measures where hemoglobin is actually amount of the heme and the globin that's in our circulating volume. Hematocrit is a percent of plasma. So you may have the same hemoglobin, but if you're fluid overloaded, your hematocrit will be low. A patient with a congestive heart failure who's not anemic may have a normal hemoglobin, but they may have a low hematocrit because they have too much intravascular fluid, for example. And what your end organ needs is the amount of oxygen carrying capacity of the hematocrit. So those are 2 different metrics we look at. And that the differential count, as already alluded to, is a part of the CBC, which differentiates between eosinophils, neutrophils, lymphocytes. So if a patient has a viral infection, their white count may be elevated, but if you look at the differential, the lymphocyte may be elevated. Whereas if a patient has a bacterial infection or urine or pneumonia, their neutrophils may be elevated. Platelet count is to evaluate a patient's ability to stop bleeding, and the platelets are the primary defense of that prevents us from bleeding to death. Essentially, forms a platelet plug while the coagulation pathway starts working. The red cells are like a donut, a hole in the center. It carries the oxygen, and its job is to essentially take the oxygen from the lungs and carry it to end organ. There is a passive diffusion that goes through, and the key with the red cells is it needs to have that donut-shaped, very pliable, flexible structure to be able to pass through the organ to be able to carry the oxygen. when those red cells become deformed, friable, or their shape changes, then they end up not being able to do their job. And one of the classical example of a structural problem with red cells that translates into functional problem is sickle cell anemia. And in sickle cell anemia, you have on a physiological, on a laboratory study, the numbers may look okay, but when you look at it on the microscope, the red cells are deformed and they're not able to go to the capillary. That's why patients with sickle cell end up with a lot of ischemic type pains of abdomen and small blood vessels that the sickle cells plug the blood vessels. The mean corpuscle, mean cell volume or mean corpuscular volume measures the average red cells. This is a secondary measure of us telling how active a patient's bone marrow is and whether the patient's bone marrow is in an acute active state or it's in a sort of a stable state. And think this way, as our bone marrow produces a pleomorphic cell, which is a principal Lego cell that it differentiates into white cells, red cells, platelets, and so forth. As that cells moves at a certain speed, it produces uniform set of cells that everything looks the same, more or less. If for whatever reason the bone marrow has to kick out more cells because that conveyor belt has to move faster, there's less accuracy to the size of the cells that are produced. So when we look at the MCV, we want that number to be relatively small, meaning that under microscope, when you look at the red cells, they're reasonably uniformly. High MCV means that something is triggering the bone marrow to not process these cells at a timely fashion and ends up immature cells into the bloodstream. So this can be a sign of an infection, a bone marrow disease process, and or some sort of a systemic inflammatory reaction that's causing the bone marrow to act up. Hemoglobin and MCV again, iron binding capacity and percent saturation. I've said this previously too, and it's always important to appreciate that iron deficiency anemia is only one aspect of the symptomatic anemia. We always overlook the fact that you may have a lot of iron in your system, but if your protein is low, you will not have the globin part of the hemoglobin. Let's not overlook that. And I think as weight loss surgical patients, particular risk with regards to the malnutrition, that's always something that we need to keep an eye on. We also need to think about blood loss, periods, heavy periods for female patients. This is something that very frequently is overlooked, as even if the blood loss does not change over time for a female patient, if my iron absorption is reduced, then the percentage of my blood loss to my absorbed iron is significantly worse after surgery than before surgery. And over a long period of time, that can exacerbate or bring on iron deficiency anemia. So one of the lines that I use with patients in the office is that to try to impress patients to make sure you become very proactive with your OBGYN and your primary care, not to discount any ongoing losses as, well, this is what I was doing before surgery, I'm going to be okay with it long term, which you will eventually catch up with patients. In lieu of what happened to Joan Rivers, I guess I've been asked to make a comment about endoscopy. After all weight loss surgical procedure, with the exception of the I think GI bypass, which no one does anymore, every patient can have a colonoscopy, enjoy it. The only catch point would be to make sure you get a good prep. That means that you have to have probably as a duodenal switch patient, you have to have maybe 1 or 2 extra days of the GI prep. And as far as the endoscopy is concerned, with both the sleeve and the duodenal switch operation, your upper endoscopy will be essentially on the ventral. You should be able to have the examination of the esophagus, stomach, pylorus, and post-pyloric duodenum. With the sleeve gastrectomy, you can have the ERCP, which is a procedure to access your biliopancreatic plumbing, whereas with the duodenal switch operation, you cannot have ERCP. And those of you that have had our business card, you can see that that's on the back of our business cards printed, that you cannot have an ERCP. And interesting enough, I've been called by patients from the different places. Our patients that say they were taken to the GI suite to get an ERCP done because of elevated liver function. They couldn't do it. Well, it's anatomically impossible to do an ERCP. Going back to the differential count, I already alluded to this as to you're looking at a neutrophil and a lymphocyte. Essentially, these two large cells are all white cells, so they're just different types of white cells, and depending on whether it's a neutrophil or a lymphocyte or eosinophil, they represent different types of infection and or inflammation that they're fighting. Platelets are the smallest type of the bone marrow product. They are the first defense line that prevents us from bleeding, and essentially by a number of mechanisms, they are called to action to go and plug a hole at the end of the blood vessel or side of the blood vessel, and they form what's known as a platelet plug. Platelet plug then by itself triggers a whole bunch of mechanisms that causes coagulation pathway to take place. The thing to remember is that platelets have a life cycle of about 7 to 10 days. Aspirin irreversibly blocks the clumping of the platelets. So when a patient takes aspirin for 2 days or so, essentially majority of their platelets will have some level of dysfunction, and they will not be able to clump each other to form the initial platelet plug. That's why we ask patients not to take aspirin or aspirin type medication for 7 to 10 days before surgery, because the life cycle of a platelet is about 7 to 10 days, and there's no way to reverse that. All you have to do is wait till those platelets that have been affected by the aspirin to be replaced by new platelets that are being produced by your bone marrow, so you don't have a lot of bleeding in the operative. Electrolytes and minerals: sodium, chloride, potassium, and magnesium, and calcium and phosphorus. They are critical to normal body's function with regards to all of the fundamental and basic functions of muscle contraction, conduction at nerves, as well as hemostasis with fluid across the barriers. Calcium and phosphorus also play a significant role in addition to magnesium as the structural component of our endoskeleton to be able to hold our muscles and tissues together to give us the form and structure that we have. BUN and creatinine. BUN, blood urea nitrogen, is essentially a byproduct. It measures the byproduct of the protein processing in our system. So as our body processes the protein, it releases a certain amount of byproduct, and those in the form of a BUN and creatinine, we are actually measuring the byproduct that's released into our kidneys to be excreted out. A patient with a BUN and creatinine level of 20 or above is a crude sign of dehydration. So if my BUN is 30 and my creatinine is 1, 30 over 1, then I'm dehydrated. I need to drink a lot more water. BUN of 20, BUN creatinine ratio of less than 20 is a normal range, and that formula doesn't work obviously if a patient has renal failure and is on dialysis essentially. That's sort of a crude way of doing this. A more accurate way of doing kidney function is GFR, which is measuring volume of the urine for amount of, and accounts for what the intake was, what the output was, and process that into a formula of how much of the byproduct was excreted. Albumin, protein, and globulin, their nutritional status, they're affected by liver function. They're also play a significant role in immune modulation and diseases and healing process. Patients with duodenal suture operation and or malnutrition following any weight loss surgical procedure can develop what's known as protein calorie malnutrition versus just protein malnutrition. And protein calorie malnutrition would result in not only excessive weight loss early on, but also structural injury to the endosons, which is significant swelling, third spacing of the fluid, frequent infections, and so forth and so on. Essentially, anything that results in structural protein deficiency. Lipid profile, lipid panel, cholesterol, triglycerides, and there's a lot more emphasis now placed into HDL, LDL, and VLDL. HDL is high-density lipoprotein, and essentially it's a cholesterol molecule that has more protein attached to it. LDL, low-density lipoprotein, and that's a measured volume. And VLDL is essentially a formula that you take the HDL, total triglyceride level, and you take away the HDL and LDL. The VLDL is a relatively accurate way of measuring the patient's cardiovascular risk. There's a lot more information that's been coming out with regards to the significance of changing the lower benchmark of the triglycerides and cholesterol. And initially that had been promoted as to be a preventive marker for cardiovascular risk, whereas now the reason why there's so much statin medication being prescribed is not only to lower these as a direct measure of protecting against cardiovascular risk, but there's some science that says that these may actually be inflammatory cells by themselves. So it's not just the concept of causing plaque formation by the fact that ulceration, plaque formation because of cholesterol, but because of cholesterol and triglycerides at a higher normal level may actually be causing inflammation at the cellular level. And that's been measured like protein C and protein S level, C-reactive protein. Alkaline phosphatase, lactate dehydrogenase, and the SGOT, SGPT, or otherwise known as AST and ALT. When we think about liver function, liver is sort of the refinery, and it is stressed significantly after weight loss surgery, and that's why we sort of have the patients, avoid doing anything that stresses your liver any further. If you think about hepatitis in a form of either infectious or steatohepatitis, which is fat infiltration of the liver, the structure and anatomy of the liver goes from normal anatomy on one end to end-stage liver failure on the other end, and end-stage liver failure is only treated with a transplant. You can essentially walk up that pathway by about a 2/3 of the way and still be in a reversible condition where you can develop from normal anatomy of the liver structurally and numerically on the laboratory studies to develop some steatohepatitis, which is fatty liver, and that's very commonly seen in overweight patients, post-weight loss surgical patients, even seen frequently with patients that are on diabetic or cholesterol medication. And then the next stage is fibrosis, where you actually start seeing scarring of the liver under microscope, where those patients, if you take away what's causing the stress on the liver, structurally it will not go back to normal, but physiologically laboratory studies will revert back to normal value. Once you get to early cirrhosis is where it sort of becomes the point of no return, and the only direction things can go from a cirrhotic liver is to go from bad to worse. All you can do is to prevent it from deteriorating in a worse condition, which is why avoid Tylenol, anything that stresses the liver, alcohol, significant rapid weight loss, or anything that stresses the liver with regards to the food. We many years ago published on this because we used to see, and we'd always known that after weight loss surgery, patients' laboratory studies with regards to liver function will get worse, and that would cause a lot of patients and primary care to get concerned about it, and they'll then undo a number of laboratory studies. Actually, patients 6 months out are getting liver biopsies for no good particular reason. So we published a study, and we have this on our website, where we did a whole bunch of liver biopsies on patients that are having weight loss surgery, and then within the following, in 1 year after that, same patients, if they're having any other procedures, we would still do liver biopsies, and all samples were randomized, and we were able to show that During the first 6 months or so, there is some worsening of the liver function where the LFTs go back and they get worse. But after that, they come down, and as the BMI came down, the liver function test came down to below what was before weight loss surgery. So take-home message with this is, do expect your liver function test to get worse for the first 6 months to a year, and there's no reason to get alarmed. It'll come down and normalize essentially. A thyroid function test, one of the basic indexes that we see is thyroid stimulating hormone, the TSH level. There's a loop regulating loop from thyroid to the hypothalamus and back, where if a patient has enough level of thyroid function, thyroid hormone in the circulating bloodstream, then your thyroid stimulating hormone should be relatively low. As my thyroid hormones goes down, that sends a signal to my brainstem saying that I don't have enough thyroid in my bloodstream, so your TSH will go up to kick the thyroid to make more thyroid hormone. So a quick and dirty way of assessing a patient's thyroid function or raw thyroid function would be to check the TSH level. Now, this doesn't account for the other potential pitfalls of resistance or antibodies, Hashimoto's thyroiditis, and so forth and so on. But the quick and dirty way of evaluating the patient's thyroid function. One of the things that we find ourselves contradicted sometimes with endocrinologists and or primary care is when we are looking at a patient who comes and describes signs and symptoms of hypothyroid state. I'm gaining some weight. I find myself depressed or fatigued all the time. I've got a lot of hair loss. And I'm not talking about a patient that had weight loss surgery 2 weeks ago. I'm talking about a patient that has had weight loss surgery 6 years ago. They're stable. Everything is status quo. Nothing has changed, but they're developing these new symptoms. And that they've been on the same thyroid medication for the last 5 years, and their TSH is still in normal expected range, but higher than it was before. As surgeons, we feel comfortable to treat those patients as if they're clinically hypothyroid, upping their thyroid medication, whereas non-weight loss surgeons may be reluctant to do that because they'll say your thyroid TSH level is normal. The rationale for being careful with not increasing the thyroid hormone is because that there are cases of osteoporosis described in patients that are receiving too much thyroid medication. So it's a double-edged sword where you have to sort of evaluate each patient individually and treat them based on their symptoms. A urine analysis is a test for evidence of urinary tract infection, diabetes, kidney disease, or liver disease. One of the frequent things that we see is what we call red cells in the urine, and that's early sign of a patient potentially developing calcium oxalate crystals. Calcium oxalate crystals form in the urinary tract when a patient is not absorbing enough calcium, and you've heard me say this before, that what patients need to do is not only take their calcium they've been taking before, they should start adding more calcium within their meals to absorb and bind the oxalate that's in the food to prevent it from being absorbed. As calcium oxalates are formed in the collecting ducts of the kidneys, then they scrape the inner lining of the epithelium, and the patient ends up with blood in their urine. So first sign, a warning sign of a kidney stone in process coming. So we should be able to sort of clear that, and the urine analysis will tell us that not only there is some trace blood in it, but also there's calcium oxalate crystals. Blood is not normal in urine and needs to be evaluated and looked at to make sure there is no other possible causes for bleeding within the urinary tract, such as a tumor, good or bad, needs to be looked at. Vitamins, I think we've talked about this hundreds of times, so this is 101 time. Water soluble, fat soluble, there's 8 B complex vitamins and vitamin C. Limited body stores, so we need them relatively frequently as far as water soluble is concerned. There's been strict guidelines recommended daily allowances described for both water and fat-soluble vitamins. And most of us realize that those numbers are extremely conservative, and most of us can get away with a lot higher doses. I'm not saying a lot higher doses are any better. It's just that we can get away with a lot more than worrying about if I took an extra dose or not. Fat-soluble vitamins, I'll talk about it in I think next slide or two. Vitamin A, vitamin D, vitamin E, and vitamin K. They're always fine as precursors, and there's some processing that needs to take place. Because they're fat-soluble, their deficiencies do develop slowly over time, and in order to correct the deficiencies, it'll also take as long, if not longer, to bring them back to normal range. Vitamin A, there's essentially two ways that it addresses that we see clinical issues with it. Night blindness is one of them. A chemical reaction involving the rods and the cones that cause electrical change in the optic nerve, and that allows us to see the image that we're seeing. And the second way that vitamin A is important is maintains a healthy cornea, the lens of the eye. Night blindness is one of the first signs of vitamin A deficiency. Vitamin A is also important in bone growth. It's an antioxidant and epithelial cell. Just a hand in the raise of the hand in the room. How many of you know what night blindness is? I know we may have heard about it. Do we actually know what night blindness is? We'll show that in a sec. Vitamin D, it's a unique vitamin. Our body can make it from cholesterol in multi-steps. We talked about this, I think, last time or on one of our talks that's on our website about vitamin D. And one of the reasons why we're having problems with vitamin D is because everyone's on statin medication right now. We're scared to even see the sun. So we cover ourselves to no end and take a whole bunch of statin medication, and we wonder why vitamin D are so low. So everyone should go out there and start exposing yourself. There's two types of vitamin, 125 and 25 hydroxy. It's also very important to take this in conjunction. If I give you a prescription. Get out of jail free time. In conjunction with calcium, PTH, alkaline phosphatase. There's one of the, when we're looking at laboratory studies on a patient, every so often a patient, PTH may not be ordered by your primary care. Every so often, we'll see a patient coming back with a normal calcium level and elevated alkaline phosphatase. That's a warning sign that you're not taking enough calcium or absorbing calcium. There's two isomers of alkaline phosphatase, and isomer is the technical term of the Lego pieces that are the same two pieces except they're placed in a different angle, for example. One isomer comes from the kidney. One isomer comes from liver or the biliary tree, and the other isomer comes from the bone. So by elevated alkaline phosphatase of the bone isomer, we can tell that a patient's bone is being broken down to keep a normal calcium level, and one of the byproducts of that is an elevated alkaline phosphatase level. So when I see the patient with no PTH level, normal calcium and alkaline phosphatase, we routinely say, well, there's something brewing underneath. We need to check your PTH level and magnesium and look into this a little more deep. Long-term surveillance for vitamin D is these are two images where you can see on the left sort of a relatively normal-looking bone density and so forth, where on the right you can see how there's osteophyte formation and there's a significant more transparency to the bone. So even though the bone has not only lost some fracture, it has lost some structure, there's a pathologic fracture, but there's also hypodensity, luminescence of the bone that says there's loss of calcium and mineralization of the bone. Long-term surveillance of vitamin D also can be done by T-score of the bone other than a plain X-ray. There is some controversy as to what the significance of the T-score per se is. The bone scans, and there's a DEXA scan. There's some that measures ultrasound waves. There's some that measure nuclear reactivity of the bone. It's very important to appreciate that for the most part, these are all trend indicators. There's a lot more value to say my T-score was a certain number last year and there's one today versus make a definitive decision as to what my T-score was this year and what to do with that number. So it is important to bear that in mind and not necessarily get all excited about what my T-score is per se. I also want to sort of take this point and talk a little about the biphosphonate class of medication. One of the most famous one is Fosamax that everyone talks about. And my description of what Fosamax does is it takes a brand new drywall and put it on an old drywall. And so if you have mold on the framing, all you're doing is you're covering it up, and eventually it will come out and it'll sort of show its surface. The bisphosphonate class of medication was actually initiated for treatment of patients that were undergoing chemoradiation for breast cancer, and in order to minimize the impact of bone loss. And the way it works is that it favors the build-up phase of the bone breakdown and slow down the bone breakdown phase of the bone processing. Our bones, our skeleton goes through a continuous revamping. So there's cells that break down the bone structure, there's cells that make the bone, so our bone is continuously recycled, and that's always in a fine balance. So if someone falls down and break a bone, then you reduce the cells that break down the bone, you bump up the cells that make the bone, so you cover the fracture area, and then over time it reorganizes and ends up forming the bone. So patients that were having chemoradiation for breast cancer used to have a much higher breakdown side of the cycle, and they would become osteoporotic. So bisphosphonate class of medication came up to solve that problem. And we've taken this and have applied that to other patients that are also having osteoporosis. The problem with this is that though if a patient does not have enough calcium in the system, this can backfire, and in some cases it's been shown to cause pathologic fracture of the jaw. And this is sort of an example of how that can happen with causing a cavity and jaw fracture after taking bisphosphonate. Also want to talk a little about vitamin K. Long term, it can cause easy bruising. So as we remember early on, we said our first mechanism against bleeding is forming a platelet plug, where it causes sort of plugs the hole, and that can only last for a short period of time. That triggers a set of mechanisms which draws in all of the coagulation factors, and then one of the cofactors, in this case the vitamin K, is critical in allowing for that final step of, along with calcium, the final step of the coagulation pathway to take place, to replace that temporary platelet plug with a permanent structure to prevent us from bleeding. There's two types of K. The K1 plays a significant role in clotting system, and K2 plays a role in cardiovascular health and protection. And I think there's a lot more also changing vitamin K science and our understanding, and I'm sure there's more to come on that.